All right. Good morning or good afternoon, depending upon what part of the country you are joining us from today. Welcome to our webinar, Simplifying Billing for Medicare, a start to finish process. I appreciate you all taking time out of your busy schedule to join us for this session. I'd also like to take just a moment and thank Pekka for giving us the time to conduct the session and share some information with you all. We are excited to hopefully give you some good tidbits today that'll make everyone's job a little bit easier, especially as we roll into some of the busiest time of the year for all of us. My name is Melissa Jacobson. I am the operations manager here at RevCycle Partners. I am responsible for the team of billers that deliver our service on the Rev EHR platform. I have been with Reb Cycle Partners since early 2019. Prior to that, I actually spent 12 years managing a 10-location optometric practice in Northeast Florida. I actually started there as a technician and worked my way up to the chief operating officer. So I do have a little bit of a unique perspective that hopefully you guys will find useful today. I have with me Casey Squicquero. She is our staff development manager. Casey, would you like to take a moment and introduce yourself as well?
Sure. My name, again, is Casey Squicquero. I have been with RevCycle Partners since 2014. I, just like many of you, started inside of an office, learning all the aspects of optometric billing and just the aspects of working inside of the office. So I have been in my current position as the staff development manager with RevCycle Partners for almost 4 years. And in this position, I assist our team of billers with ongoing training and billing support.
Very good. So Casey is going to be the presenter for today's session. I will be tag teaming along with her here to monitor any questions that you all have. If, as she goes throughout the presentation, if you would like to type any questions that you have into the question and answer box or into the chat box, we will have a Q&A at the end of the session. Throughout the presentation, everybody will be muted today just for the sake of time. However, we will be answering questions at the end, so please feel free to go ahead and type them in. Additionally, we are recording today's session and we will send that out afterwards. If you would like a copy of the recording, we will send that and the slide deck out post presentation. All right, and with that being said, I'll let you take it away, Casey.
Thanks, Melissa. Okay. So let's get started here. And Melissa did mention, so for the sake of time, everyone's going to be muted. Feel free to submit those questions via chat. I do want to mention also that you may see some links throughout the slides. I have those links on some of the slides as reference points. I have provided Pekka also with a quick reference guide that has a copy of all of the links. So they should also be providing that to you as well. So I'm not going to train specifically or click into the links. Some of them will take you to Medicare tools. I'm not going to train on those today, but I will provide you with a copy of those links for your own reference. So to get started, I think we all can appreciate that Medicare can be difficult to understand. And that's not just for a biller, but it's for all of your staff. It's also can be very complicated for your patients. So finding ways to keep everyone one step ahead of what to expect with Medicare and setting expectations with your patients is key in simplifying this process. So what I hope to accomplish today in this webinar is to give anyone who is struggling with billing Medicare a better understanding of the process from beginning to end, and anyone who's not necessarily struggling with it, I hope to give you at least some tips on how to stay one step ahead still. So when I think of the issues I've encountered in the office regarding Medicare, even that I've encountered daily working remote billing, I think the place that it starts with is credentialing and what your staff knows or doesn't know about all of the different payers. Does your staff know if you're credentialed with traditional Medicare, with Railroad Medicare, or with DMERC? What about the various Medicare Advantage plans offered through payers like Blue Cross Blue Shield, United Healthcare, Humana, and Aetna? Make sure that all of your staff is aware of the plans that you're contracted with, or even if it's easier, make a list of those plans and keep it in a common place. Even keep a list of the ones that you don't accept. Have it available and accessible for all of your staff. You don't want just your office manager and your insurance billers to be the only ones who know what plans you do accept. This becomes a problem if staff members who are answering the phone don't know. Scheduling appointments, staff members that are checking in your patients. You want everyone to be successful in setting up accurate billing and payment expectations. So be sure to educate staff that if you participate with traditional Medicare, that it doesn't mean that you're automatically enrolled in Railroad Medicare or automatically enrolled in DMERC. The same goes with any of the Medicare Advantage plans. All of these plans, although referred to as Medicare by your patients, can all be separate enrollment. If you're just beginning the credentialing process, traditional Medicare is always the best place to start. Several medical plans, including Medicaid in some states, will not credential you unless you are approved or at least in processing with Medicare. Once credentialed, don't let your CAQH lapse. Almost all insurances rely on that database to confirm your status. If you're not credentialed, you may not get paid, or your claims may process out of network, both of which mean higher out-of-pocket expenses to you and your patients. After you understand the credentialing process, the next logical step is to understand the plans and the coverage that's offered under them. Let's face it, I mean, all of our patients, we want them to be held accountable for understanding their own insurance coverage. However, most of your patients, especially the ones with Medicare, they are often confused themselves, and they really do look for you to guide them. The more you know about the plans, the better chances you have with being paid quickly and being paid correctly. So details of your patient's plans, they can change from one visit to another. This includes deductibles, copays, plan types, plan changes. They often happen year to year, but they can happen visit to visit. They can happen month to month. Sometimes it's based off of income level that causes some of the plans to change. It can be because of premiums not being paid. So what was covered at the last visit may not be covered at the current visit. Possibly the plan changed from a PPO to an HMO, and now a prior authorization is required with an HMO. It's important to gather all of the patient's information as well as make copies of the fronts and backs of your patient's insurance cards at each visit. You can even gather all demographic information, insurance details days before your appointments, before your patient's appointments. Setting expectations of coverage and out-of-pocket expenses with your patients before they're seen helps to set a clear expectation and ultimately will result in less calls into your office regarding patient billing. When dealing with Medicare, be sure that you're getting all of the insurance cards. Many Medicare patients will present you with just the traditional red, white, and blue Medicare card, regardless of if they have an Advantage plan. They may also fail to give you a copy of their supplement insurance. So obtaining copies of all the cards will help you to determine who should be billed and in what order. It'll also ensure that you have the correct ID numbers, the correct spellings of their names, as well as the correct payer IDs. Also, setting up access to your state Medicare portal, it can be a very important tool. It allows you to check patients' eligibility, claim status. It'll allow you to file claim corrections. It'll also show you any patient deductible amounts that have not been met, any additional insurance coverage. It can be a little bit tricky to enroll and set up access to the Medicare portals, but in the long run, it is well worth it, and it pays off tremendously. So I want to talk a little bit about understanding the different parts of Medicare. I think this can help your staff and yourself to understand what to collect from your patients up front. It also helps you to understand what order to bill your patients. So Medicare is made up of 4 parts. The first part is Part A, and this covers your hospital, some skilled nursing, and hospice services. Part B will cover outpatient services. This is the portion that we're billing to providers for office visits. Part B reimburses at 80% of Medicare's total allowable after their deductible has been met. If the patient has a supplement or a Medigap plan, it can pick up the remaining 20%. And some supplement plans will also pay for a portion of the yearly deductible. If the member is properly enrolled and coordinated, Medicare will automatically forward claims to the supplement. This information, you will see it indicated on your explanation of benefit that you receive from Medicare. Supplement plans are in addition to Medicare. They're always second to traditional Medicare. So when you're credentialed with Medicare, you're automatically credentialed with the supplement Medigap plans. Part C is an alternative plan called a managed Medicare or a Medicare Advantage plan. This plan allows your patients to choose health plans that are at least the same service coverage as Part A and B. Most times it's better coverage. These plans can have coverage for prescription. It can have a separate vision benefit. This plan is sometimes referred to as a Medicare replacement plan because it replaces traditional Medicare. You'll bill the Medicare Advantage plan as the primary payer. When the patient has this type of plan, you do not bill traditional Medicare. Another important difference with Medicare Advantage plans is if it's an HMO plan, there would require a prior authorization or a referral from the member's PCP. So this information is important to identify before you see your patients. Part D is prescription coverage. The patient also may have a separate insurance card for prescription coverage. So checking patients' eligibility and benefits will help you to determine what types of plans they do have. I want to just kind of reference in this next slide a little bit more information regarding Part C and the difference between Part C and some confusion you might get with the supplement cards. So finding ways to be successful, be a critical thinker, find ways to have indicators of what plan you would bill primary, what plans would be secondary. So in this example, the left-hand side is a Medicare Advantage plan. This is an Advantage insurance card. This is going to be billed as a primary payer. You'll see indicators on these cards where it says Medicare RX down in the bottom right-hand corner. You're going to see the payer ID listed with a PCP, a specialist copay. This replaces traditional Medicare. So you're not going to bill the traditional Medicare plan. These will indicate on them whether they are an HMO plan, usually down in the plan name, it'll indicate that. On the right-hand side, this is a Medicare supplement plan. You'll see verbiage on there that does say supplement. You'll also see things listed such as Plan F, Plan N. Medigaps have different plan coverage based off of these plan type indicators. You will always bill a supplement plan secondary to traditional Medicare. Another small way to stay one step ahead of Medicare is knowing some facts about Medicare numbers. So updates were made to Medicare cards back in 2019. The new Medicare ID numbers are referred to as MBI numbers or Medicare Beneficiary Identifiers. Before the MBIs, the patient's Medicare ID numbers were called HICN numbers. They were the patient's Social Security number. As of January 1st, 2020, Medicare will only accept the MBI numbers listed on the new cards. The MBI has 11 characters. They are both numbers and uppercase letters. However, if you use a lowercase letter when you file your claim, Medicare's system will automatically convert them to uppercases. The numbers range from 0 to 9, and the letters range from A to Z, with the exceptions of excluding letters S, L, O, I, B, and Z. So eliminating those 6 letters were done in order to make the ID numbers easier to read verbally through the IVR. And I especially find this helpful whenever your patients call in, maybe they didn't bring the insurance card with them, and they call in to give you the number after the fact. Knowing that these 6 letters are not ever in the ID number should help you to eliminate some of that verbal confusion when they're speaking those letters. One other thing I do want to mention is that, and although the ID numbers do have dashes on the card, you never want to enter those dashes in to your system. So leave those out of the ID number. It will cause the claims to reject. So another important topic regarding Medicare is QMB. So QMB stands for Qualified Medicare Beneficiary. This is when a person qualifies for Medicaid in addition to Medicare. This means that they're at 100% of the federal poverty level. And this is a program where the state pays the Medicare premium and the cost share amounts on behalf of the beneficiary. Medicare and Medicaid members qualify for this program only on a financial need basis. So if a QMB recipient is seen for services, any deductibles, copays, or coinsurance for Medicare eligible services will be forwarded and paid by Medicaid at the Medicaid allowable amount. So in the instance that your provider is not participating with the state Medicaid, they are unable to collect any of that remaining cost share amount directly from the patient. Also, for providers who are participating in Medicaid, if the cost share amount is over the Medicaid allowable amount, then you won't receive any additional payment from Medicaid. Federal law forbids Medicare providers from billing members in the QMB program for Medicare cost sharing. Medicare beneficiaries enrolled in the QMB program have no legal obligations to pay Medicare Part A or Part B deductible coinsurances or copays for any Medicare covered items. If you're a Medicare provider but not a Medicaid provider, this still applies to you. On the other hand, this would not apply to something such as a refraction. Since refractions are not Medicare eligible, they are out of pocket to the QMB recipient when not covered by a separate full Medicaid or Medicaid MCO plan. So as a biller, it is important for you to be your doctor's advisor. And in order to do so, you need to be sure to understand what Medicare's billing requirements are. So understanding these requirements are needed in order to accurately bill and code your claims. Partner with your doctor to make sure claims are coded correctly. If you see errors or any potential for errors, be sure to discuss them. If you provide a good service and you have a good delivery of service, as a biller, you should be educating your provider on payer rules and requirements as you're coming across those. This will ensure that your claims go out correctly every time. It normally does fall to the biller to truly watch out and protect their doctor and ultimately their patients on correct coding and claims filing. So the links on this slide I find extremely helpful for billers with all levels of experience. There is the Medicare coverage database, and this can provide you with a list of covered diagnoses that are covered for certain CPT codes. When billing certain medical tests, the diagnosis can determine the frequency of how often you can bill something. This tool can also provide you with coverage articles from your Medicare contractor. These articles may be able to get you the coding information that you need in order to accurately bill. A lot of times these articles can get you the correct information in order to file appeals as well. Another tool that you should be familiar with is called the Procedure to Procedure Lookup tool. So this was a tool that was established by the Centers for Medicare to promote national correct coding and prevent improper coding of Part B claims. The tool tells you when two bundled codes performed on the same day can never be billed together when they can always be billed together and sometimes be billed together. When that sometimes can be billed together, there does need to be it needs to be clinically appropriate and billed with the appropriate modifier. So a common example of this in optometric billing would be billing a fundus photo and an OCT scan at the same visit. NCCI will allow for the unbundling of those services as long as the documentation in your patient's medical records support why both tests were needed. And the services would need to be billed with the appropriate X or 59 modifier. So the NCCI lookup tool, the procedure to procedure tool, will indicate what procedures fall under those bundled rules. Also, I have a link to the physician's fee schedule. So the physician's fee schedule is a tool that can give you different information about a service, such as your pricing amounts, your allowable amounts, the global periods for CPT codes, bilateral surgery indicators. And the bilateral surgery indicators tell you when a same-day service is performed multiple times, whether or not you need to bill a right and left modifier with that service, or whether the service requires that you bill the 50 modifier with it. So to stay one step ahead, you also need to know about advanced beneficiary notices. So the advanced beneficiary notice helps Medicare fee for services, items that are usually covered, but in some instances they are non-covered in specific situations. So the ABN must be completed for patients where you expect Medicare will deny a typically covered service because of medical necessity. So be sure that the expected cost to your patient is listed on the form. Make sure that it is current to the date that the patient's being seen. ABNs are only necessary for covered services, so they're not needed for excluded benefits such as refractions. Be sure that your staff reviews the coverage requirements and criteria for these ABNs. Also, I do see sometimes where maybe an ABN is being used, a Medicare ABN is being used as like a blanket ABN form for all payers, and that really shouldn't be the case. You do need to look up to see if a payer besides Medicare, they may have a specific non-coverage form or ABN that should be filled out for their members, and you shouldn't necessarily be using a Medicare ABN form for those commercial payers. So all of the steps that I've talked about are really steps that are prior to billing your claims, ways for you to prevent denials. But for this last step, I just want to remind you all to follow up. So there are definitely preventative steps that you can take on the front end, but there is a lot of times going to be follow-ups that are still needed on the back end. So if you get a denial, you really need to understand what the denial code is telling you. So with Medicare, I will say that one of the frequent denials that you might see is a CO 109. This denial states that the patient's covered by a managed care plan. This denial normally happens when you have billed traditional Medicare and the patient has a Medicare replacement plan. So look in the patient's chart. Hopefully you have copies of the fronts and backs of the cards. So when you look in the patient's chart, see what that card looks like. Do you see any indicators that I mentioned in the previous slides that tells you whether or not that patient has a Medicare Advantage plan? And if you see that, then that's the payer that you're going to bill as primary. Medicare Part B will not be billed at all. So before you transfer something to your patient or write something off, be sure to ask yourself if it's an error that can be corrected and can it be refiled. You also want to pay attention to the timely filing rules. Traditional Medicare allows for 1 year, but there are Advantage plans that may have a shorter timely filing. Also for Medicare, Medicare does not allow for you to file a replacement claim like you might be able to file to some of the Medicare replacement plans. For traditional Medicare, you do need to refile a reopening or a redetermination for denied claims. It's another reason why it's really important to have access to your Medicare portals so that you're able to submit those reopenings and redeterminations on there. Just be sure that you do your due diligence before giving up on the claim. Be proactive, and I mentioned before too, be a critical thinker. So, I mean, that kind of sums up the presentation. In closing, I just kind of want to mention a couple summary tips. We talked about your office's credentialing status with the different Medicare plans, but be sure that your staff understands those differences and what to look for on the insurance cards. Get all of the insurance cards from your patients at each visit. Ask for details when you confirm appointments. Use the portals to check eligibility. I did mention the various ways to stay ahead of errors, understand the MBI format. Use those different tools that are available, the NCCI edit tool and the coverage database tool. Understand your denials and your timely filing deadlines for follow-ups. And you should also know when you should or should not be using an ABN form. Some of the questions to ask once you've determined plans is the policy an HMO or a PPO? Do you bill traditional Medicare or are you billing a Medicare replacement plan? If it is an HMO, make sure that you know whether a prior authorization or a referral is needed. Ensure that you know who the patient's PCP is so that you can either have your patient get that referral or you're able to call the PCP. A lot of plans don't allow for backdated prior authorizations or referrals, so you want to catch that ahead of time. See if there's any visit limitations for certain conditions like glaucoma or diabetes. If the medical policy does have vision coverage, is that listed under a separate insurance payer? And if it is, many times the patients will not have a separate card for those. So hopefully, I hope that this webinar offered you some guidance, some suggestions and education that can bring you and your staff ways to help minimize these pain points. I know we're finishing kind of on the half hour here. Hopefully you guys have some questions. We're gonna go ahead and open up to some questions and answers at this time. Melissa, did we have any?
Thanks, Casey. I think it looks like there might be a couple coming through. I'm going to give you all just a couple more minutes to submit your questions if you'd like. While those are coming in, I'd like to take just a moment and give you a little bit more information about RevCycle Partners. So, RevCycle Partners is a revenue cycle management company. We specialize in providing services to the eye care industry, and our team is composed of experts who have had real world experience working in eye care offices. Most of our staff have been right there inside the brick and mortar office at one point or another in their career. So we do consider ourselves expert in the industry. We actually have 3 different services, the biggest of which is our billing service. We do allow our customers to customize their portion of their billing that they would like us to assist with. So we can provide billing services for just medical claims, just vision claims, or both. Our services do include scrubbing claims, including looking for things like proper formatting on MBIs. We will also check for modifiers as needed. We do submit the claims for any medical claims. We'll do claim corrections and appeals. We also post insurance payments and we'll work your aged claims. So in addition to the ongoing billing service, we do also offer an AR or an aging cleanup project for any claims that would otherwise be outside of our services. If, for example, you've fallen behind on your aging and just need a little help catching up, but don't want to have us take over your billing in full, you can sign up for just a limited time AR cleanup project. Our fees are based on net receipts. We do only charge a percentage of what you are paid by the insurance company. We do not include patient copays, deductibles, or coinsurance when calculating our fees. For medical claims billing, we charge 7.5% of net medical receipts. And for vision claims billing, we charge 4.25% of net vision receipts. For the AR projects, those are custom quotes based on the needs of your office. I do have some contact information here for us. If you are interested in getting any more information about our services, we'll leave this slide up during our Q&A so you can grab our contact info. But with that being said, it looks like we've got a couple of questions, Casey. The first of which is a request for you maybe to hop back to that fundus billing page and just talk a little bit more about the link that's on that page regarding billing. And then we can go back to that contact slide once you're done.
Okay, this one here, I think that would be it.
Yeah, so there aren't any specific questions, just a general question. If you could kind of maybe reiterate, how these links would be helpful when it comes to fundus photo billing.
So we have, it doesn't mention like one specific one, just to kind of mention each of them. Okay. So the Medicare coverage database, this link will take you to Medicare, to CMS's coverage database tool. So depending on your state, you'll pick whoever your contractor is. And then there are, depending on your state, different articles or LCDs that are available that might tell you when it is appropriate to bill a fundus photo, what diagnoses are covered underneath, will be covered as far as payable when billing a fundus photo. For the NCC procedure to procedure lookup tool. So this would be beneficial if, as far as a fundus photo goes, the tool will tell you, and it's standardized, it's national. So it'll tell you what codes a fundus photo are bundled with. Are there any codes that you shouldn't necessarily, or they won't pay as a standard billing together. So it'll give you an indicator of, it's normally not allowed for separate billing, but in the case, it will indicate, the ones that, yes, you sometimes can bill a fundus photo with this code and unbundle it as long as your, medical records or the necessity of why you feel you need to bill something like a fundus photo and an OCT together. Your note should clearly be documented and indicated why, and it needs to fall underneath the exception rule. And then there are the 59 modifier or the X modifiers that would come into play in that case that you would add to unbundle them. So, NCCI procedure to procedure, just kind of think of that tool as indicators on what codes are bundled together. And then the physician fee schedule, as far as a fundus photo specifically, you'll be able to get some information based off of how much does it reimburse, how much should you be getting paid for that when you're billing that service. It is going to be contractor or state specific as far as your fee schedule goes. I don't, global period, fundus photo doesn't have a global period. And then as far as a bilateral surgery, so a fundus photo, you would bill once on your claim on one line item. So I don't know that the bilateral surgery indicator would really be helpful as far as specific to a fundus photo. But each of the tools, it gives you documentation on the website, and it kind of tells you exactly what the tool is used for. And it does give you a quick reference on there too, that kind of helps you to decipher a little bit about, what the indicators on those tools, what they mean. So you got to look at it as kind of like a key or a legend to kind of decipher some of the ability to use these tools.
Very good. Thank you. And just to reiterate, we will be sending out a copy of the presentation after the webinar. So you'll have these hyperlinks available to you post-webinar, so you don't have to write them down. You will get a copy of this. Now, Casey, is there a particular portal you recommend when it comes to Medicare? What's the best way to access all things Medicare patient related?
So it's going to be whatever portal is specific to your state. So sometimes we don't really realize that Medicare is, we're used to billing a Medicare contractor based off of our state, and that's kind of all we know. When you're billing more for a billing service and you might be billing multiple states, you will realize that there are, I don't know offhand if there's 7 different Medicare contractors. There's Noridian, there's Novitas, there's CGS, there's multiple. So you have to know which contractor is yours. And then on that contractor's website, you'll be able to get access to information on how to register for the portals, as well as the link to the portal where you would need a username and password to get logged into it. That's where I would suggest you go for all patient specific information. CMS's website is where I would refer you to for just billing, Medicare in general type information.
And I'll add to that just a little bit that if you have, sometimes offices will have it set up, for example, like through their clearinghouse to be able to check some Medicare eligibility information for patients. Nothing really quite replaces the Medicare website itself. I would encourage you all, if you have not yet created a login for yourself, for your office, for that Medicare portal that Casey was mentioning, you should go do it. That's where you will get the most accurate information and have the most functionality in terms of things like Medicare reopenings and appeals and such. Some contractors, you have to have access to the portal to file Medicare as secondary claims even. So I would definitely recommend those portals. I'll second that. All right, so here's another question. It's more a clarification, please. She says, I just want to clarify that if we are a Medicare provider, that it automatically makes us payable with any secondary payer. In other words, we don't have to credential with a secondary payer if we're properly credentialed with Medicare.
So and Melissa, you might add to this a little bit too. So when it comes to the supplement plans, when it comes to the Medigap plans, those automatically will be payable when you're credentialed with Medicare. The only exceptions to this would be like the employer type plans. So if, and I think this comes into play too, whenever you're in a state where maybe people tend to go to off seasons and it's an employer-based plan, and you may be considered out of state for that, or you're not credentialed for it. Those types of plans would be the only exceptions to that rule. So if it's a standard Medigap plan that's offered, like in the example that I showed with AARP supplement, if you are credentialed with Medicare, you would automatically be credentialed with AARP supplement. It would not require any additional paperwork.
And I'll just add to that, not to confuse that with the Medicare replacement plans. Yeah. So if it is a true secondary, you don't need to be credentialed. However, if it is a replacement plan, one of those Medicare Advantage plans or those managed care plans, those you do have to credential with separately. And be careful, because you may think, well, I'm a United Healthcare provider, so I'm already credentialed with this Medicare Complete plan. That may not be accurate. A lot of times when you contract with the commercial payers, you do have to request both the Medicare and Medicaid lines separately. So verify your contracts, make sure that they include those Medicare lines, and if they don't, contact provider relations and ask them to add the Medicare lines to your contract. There are often multiple Medicare lines even, so simply participating, for example, with United Healthcare Medicare Complete Plan does not necessarily mean that you participate with all United Healthcare Medicare plans. So watch your contracts carefully, and if you come across one that you're out of network with, make sure you contact the payer and ask to add it if you want to. So just watch for that. There are two different types, and often patients don't understand the difference. They will hand you all three cards, a red, white, and blue card, a supplement card, and a replacement plan card, because they don't know what they currently have. And sometimes you have to do a little bit of digging to understand. And that is where these payer portals come into handy, because if you log into that Medicare website and you look up that patient, it will tell you if they have a replacement plan, as long as their information has been updated by the patient. Okay. Another request, if you don't mind, Casey, to go over QMB again. Specifically, the question says, for example, if the patient has not met their Plan B deductible and is a QMB member, but our office is out of network with our state Medicaid, would we collect the deductible from the patient?
You would not. You would not be able to. It's going in that rule is regardless of your provider's participation status, I should say. So in that case, no, you would not be able to bill the patient for the Part B. And from what it sounds like, you are not participating, you're not going to receive payment from Medicaid either. So it kind of does seem like a loss situation, and in that situation it really is. So when it comes to QMB, you should pay attention to your EOBs as well. You'll see on the Medicare remit, those QMB patients, there will be a remark code at the bottom of your remit that says this patient is QMB, you cannot collect any cost share amounts. So cost share amounts include deductibles, copays, coinsurance. So, and that does not just apply to traditional Medicare. That also applies to Medicare replacement plans. If that patient has a Medicare replacement plan and also is a part of QMB, you're not able to collect the copay. So that changed in 2018, where they at least now indicate that on the remits. So you should, scan the bottom of your Medicare remits each time, looking for those remark codes, so you don't miss any.
Just to clarify, is QMB the same thing as traditional Medicaid? What if the patient has traditional Medicaid? Can you collect the deductible in that case?
No. So traditional Medicaid would be, so QMB is qualified Medicare beneficiaries. So those patients or members have Medicare and also qualify because of state, their income level for those cost share. You may also have patients who are dual eligible, where they are QMB and they have a full Medicaid. In that case, you could not even collect, if they're dual eligible with a full Medicaid, you would not even be able to collect, in most cases, the refraction, because likely they have a benefit available under Medicaid that would even pay for those routine vision services or vision type services. So QMB would kind of be before a full Medicaid. Neither you would be able to collect cost share amounts off of. QMB, you would be able to collect the refraction because a refraction is a non-covered service with Medicaid or Medicare. It's not a cost share amount with Medicare.
Okay. Could you please go over how to submit a claim when Medicare is not primary? If a patient, for example, has a commercial plan through a spouse or they're a working age beneficiary, how do you then forward to Medicare as a secondary payer?
So I think Melissa had mentioned this too. So you're going to bill the primary commercial plan. And then in that case, if Medicare truly is secondary to the patient because they have, a spouse, that's still working that has covered insurance, depending on your Medicare contractor, would determine how you file that secondary claim to Medicare. So you're going to file it to the primary commercial plan. You're going to let it pay and process. Once you receive that EOB, then you're going to have to take that next step to get that claim over to Medicare. Depending on, I guess there's really a lot of factors or a few factors that could determine how you get that claim over. Most Medicare contractors, unless you qualify for some exception, you're not going to be able to just mail in that claim with the primary EOB. You sometimes can file that claim on your clearinghouse, the Medicare secondary, and you'll have to indicate on there that, that the patient is a, spouse has coverage and they are a qualified Medicare beneficiary. You can do the portal for Medicare. That's almost like your guaranteed way of getting that claim over to Medicare as a secondary payer is having access to the Medicare portal and submitting it directly on there. So those would be your two options, because in most cases, mailing it is not going to be an option.
Okay. This question says, is there a website that can help identify the plans that are Medicare and Medicaid? I think that is talking about, specifically asking again, how can you identify maybe QMB prior to the visit?
So if you have access to the Medicare portal, that should indicate on there that the patient is QMB, that you should see that Medicaid listed as a secondary. There's also, and I believe it's in the link that I gave Pekka on QMB. So I can't remember if it's called the HEX. Medicare does have a very, I've not used it myself, but there is a portal that you can register for with Medicare that allows you to identify those patients, because obviously you can't log into the Medicaid portal if you're not a provider. But offhand, and I apologize, if you want to submit your contact information, I can send you the information on what that portal is called. I would say that it's probably not the easiest portal to access, and that it would likely be much easier to identify them on your Medicare portal. But Melissa, if you have their contact information, I can send it.
Okay, sounds great. Now, in the example that you provided, Casey, of the AARP situation, who should that claim be submitted to if it says, who can I submit to AARP if I only have Medicare A and B, but patient needs a regular eye exam?
So if you were given, again, your patients could hand you cards that no longer are active, so always make sure that you have some reference, whether or not that's your clearinghouse or, access to United Healthcare portal. You can check eligibility there. But in this case, looking at this slide, this would be primary, okay? Likely if your patient handed you both of these cards, one of them is no longer active, okay? Because this would be billed by itself as the primary payer. In the case that this would get billed, you would be billing traditional Medicare primary, and this would be the supplement, the secondary to traditional.
One of the advantages of those Medicare replacement plans, a lot of times why patients do sign up for those plans is because they do have benefits that Medicare, traditional Medicare does not. So you may see a patient that has that AARP Medicare Complete, as in this example, and when you look it up, they do have routine vision benefits, perhaps through iMed or, Spectera or whomever that may be. So you would want to look that up specifically on United Healthcare's website or call United Healthcare and ask about any routine eye exam benefits.
True. Yeah, I didn't mention that. So you would bill this if it's, this is looking at it as a medical visit.
Mm-hmm. Okay. How do we get to the Medicare portal?
So you would first need to identify who your Medicare contractor is, depending on your state. And on, if it's Novitas, Noridian, once you go onto that Medicare contractor's website, every one of them have it, you would be able to get access to the portal. But you do need to identify first who is your Medicare contractor, and that's something that you would be able to begin looking at on CMS's website. If anything, you may see that the name of your contractor on your remit that you get paid off of, it should specify on there who the Medicare contractor is. And depending on the contractor, each one does have a separate portal that you access.
Very good. I've had a couple of questions asking about a copy of the slides. Just to say again, just in case you missed it, we will be sending out a copy of both the recording and a copy of the slides post webinar, so you will have access to all of those. There was a question, I think it was mostly a comment about some struggles with cataract surgery. I think maybe they're looking for some advice, Casey, on how to try and get co-managed claims paid. They said they've seen both a husband and wife. They did all of the post-op visits for both eyes. They have billed Medicare several times, made several different corrections based on suggestions by Medicare, and they're still not getting paid. It's now been 18 months. Is there any suggestion that you have to them?
So I know post-ops can definitely be tricky. I think the place to start is to ensure that you have all of the necessary information that's needed from the surgeon. So you want to make sure that the surgeon indeed billed the claim so that it allowed you to bill for post-op. And with that being said, your claim to Medicare as the post-op claim, you would bill that with the date of surgery. That would be the date of the claim. You need to have the provider, the surgeon, I should say, the surgeon's name listed in box 17 along with the surgeon's MPI. You need to bill with the diagnosis that matches the surgeon's diagnosis. You need to bill with a 55 modifier. The surgeon bills with a 54. So you want to bill with a 55. What eye was it, the right or left eye? And then normally in box 19, I will say with the exception of Palmetto, in box 19, we've had great success with listing 90 days And then the day that they transferred care to you is listed first. So for instance, if the surgery was on the 10th, they transferred care to you on the 11th, my box 19 would then say 90 days post-op, 12/11/22, to the end date would be 90 days from the date of surgery. So there, you can Google global surgery calculator. Every Medicare contractor has one of those calculators available on their website where you can just plug in the date of surgery and it gives you the date that it ends. So date of service is on your claim, or date of surgery is the claim. Box 19 has the date transferred care, the date that it ends, the surgery or the surgeon's listed in 17. Your diagnosis needs to match. The right or left eye needs to be indicated on the claim. And the only other thing is if it's a surgery that is second, so it's the second eye or the second surgery you're billing, and the first eye is still in that global period, then you would also need a 79 modifier.
And
So
I'll just add one little comment there that in this particular example, if it's been 18 months, Medicare does typically have a 365-day timely filing. So make sure you're doing those reopenings, not submitting new claims, because you're going to want to make sure that it's not getting kicked out for timely filing. And if you have to appeal it, go through that process to show the claim history, those attempts that you've made, and, you can state your case and hopefully still get paid even though it's been 18 months.
And do the reopening, because likely you're going to get a denial for duplicate, or now that it's 18 months, it's just going to automatically deny as timely.
Okay, I do think that is just about all of the questions. Let me take one final look. I know we're just about out of time. All right, one final question, Casey, and then if there's any additional questions that you have, we can respond to them post-webinar. So it says, if the patient has traditional Medicare as primary and Medicaid as their supplement, but is not a QMB, do you collect from the patient if the office is out of network with Medicaid? Do you get an ABN in these cases?
So I'm going to say to always refer to your state Medicaid, because I know that there are so many different types of plans. In hearing what you're like and how I'm hearing this as a full Medicaid, you would never bill your patients for a full Medicaid. And I do not offhand know of any type of ABN that, and Melissa, maybe you can speak to this differently, but I don't know of any ABN that is available that you get filled out in the instance of a Medicaid patient. Those patients are on these programs based on financial hardships. And in those cases, there really is no, exception to those. It's pretty straightforward as far as if you are not participating with Medicaid, you see the patient, you are not able to bill the patient for any of those services that would be covered by Medicaid.
Yep, I would agree with that.
And if it is a full Medicaid, then there are, I will say, like in a replacement Medicaid plan, you would know, okay, I do not take this plan. And possibly you just, don't see patients based off of not accepting their claim or their payer. However, when it comes to Medicare, if you accept Medicare, you can't refuse to see a patient that has primary Medicare and Medicaid as secondary because you don't take the Medicaid. You really are following the rule based off of participating with Medicare for those QMB patients.
All right. And with that, it looks like we are at time. I apologize if you had any questions that we weren't able to get to. Please feel free to send us an email if you do have additional questions that you would like answered. We'll do our best. Again, I appreciate everyone's time. Thank you for joining us today. Casey, thank you so much for all of the information. We hope you all have a very happy holiday season, and we will, I'm sure, see you again at another webinar in the future. Thank
Thanks,
you and take
everyone.
care.